They were in an absolute panic. They had just gotten their results back. They had a variant of uncertain significance that was associated with one of the genes for Lewy-Dietz syndrome. They went to the websites for Lewy-Dietz and started looking things up, and they started going through the symptoms that are listed, and they're like, I have this, I have this, I have this, I have this. Well, when we discussed it though, what I pointed out to them was that, yes, you have these things that are on this list, and maybe from a numeric standpoint, you might even have more of the things than fewer of the things, but the things that you have are the things that are the least specific.
Welcome back to the Bendy Bodies podcast. Don't change your dial. Don't turn your knobs. I'm not Dr. Bluestein. I'm one of her producers, Aron Korney, and I'm honored to be back and just having the privilege to sit down once again, putting Dr. Bluestein in the hot seat for questions from you guys. No surprise, we are full of deep dives, as always, into the most significant things that you guys want to know about. Today, we're focusing on positive life impacts. What practices, what takeaways, what kind of activities, actions, you name it. Today is all about what you can do if you have EDS, hypermobility spectrum disorders, MCAS, POTS, and any related condition that orbit. We're really going to get into what are tips and tricks that you can do to improve your life. If you're a longtime listener, you know the plan. We want you guys to feel seen. We want patients to feel seen, clinicians to stay more curious, and just help everyone feel better informed in their decision-making. And as always, the information discussed today is for educational purposes only and is not a substitute for personalized medical information or advice. Trust me, I'm a podcaster, producer who only learned how to properly use a Q-tip when he was in his late 30s. So you don't want me giving that advice. Stick around. We'll be right back with this lady right here, Dr. Bluestein, and today's hypermobility hacks.
I'm super excited to tell you about the Bendy Bodies Boutique. I am so proud of our fierce styles and flexible designs. These are created by hypermobile artists for hypermobile shoppers. There are so many fun items from clothing, accessories, home goods, and my favorite are the bags. I especially love the Weekender tote with one of the EDS Tough designs. Whether you're shopping for yourself or someone you love, there's so many options to choose from. A portion of the proceeds goes to support EDS nonprofit organizations. For more information, please visit bendybodiesboutique.com.
And we're back. Dr. Bluestein, how are you today?
I'm good. How are you, Aron?
Thrilled to be back here with you. Yeah, I really enjoy doing these with you, and it seems like people don't mind you and I just volleying up these questions from the community, and it's really nice.
I think they like it. I think they really like it.
Certainly hope so. You guys are definitely sending a lot of questions, so you can all go to bendybodiespodcast.com if you want these questions to reflect your own brain, because that's how people talk. All right. All right. First question we've got here. We got a bunch of these, so let's see what we can do. If this were the only episode someone ever listened to about EDS and related conditions, what would you most want them to understand?
I think the biggest things are that these are not rare conditions. These are not joint conditions. These are not conditions that affect only a handful of unusually flexible people. They're actually very complex whole body disorders that can affect nearly every organ system. And once you understand that connective tissue is everywhere, these like random symptoms suddenly seem to make sense. And when you recognize the bigger picture, you can stop asking like, why does the patient have so many problems, and start asking whether there's a unifying explanation. And I also really love the conversation that happened recently on a Point magazine post, because they interviewed me about EDS in dancers. And there were so many great comments from former professional dancers and, current dancers that were saying, like, I have EDS. I didn't know it when I was dancing. So again, we know that a lot of people are affected by these conditions. And if we can reach people at the soonest possible time, we can really help them to get better care and feel better.
Yeah, it's interesting. I have a friend who is a Feldenkrais teacher who was a former dancer who had all these hypermobility issues and joint issues. And her whole career changed into that when she realized how much dancers struggled. So it's interesting that you bring up dancers. Yeah, it seems like, I guess that resonates with you and your background, right? But yeah, it seems like that community is probably like a no pain, no gain group. So they overlook these things, right?
Yes, they're a no pain, no gain group. And unlike other athletes who have often a lot of resources and sports medicine specialists and lots of research. We do have research in dance. We have dance medicine organizations like IADAMS, the International Association for Dance Medicine and Science. But we still have a long ways to go in dance. And a lot of dancers are just not getting the support that they need, which is part of why I'm so passionate about helping dancers. And they're such a hardworking group. So this episode is not dance focused, but I just wanted to bring that up because I think sometimes people might wonder, well, why do I talk so much about dance? And it's because, go where the people are, right? That's where a lot of the bendy people are. And so we want to be trying to reach those high risk populations at the earliest possible stage.
Yeah. So let's go wider than that. You've done what feels like estimating 80 million episodes now of Bendy Bodies where you've talked with so many experts. What made you want to do an episode that's just focused on potentially just like the life altering, ground shifting things people need to know? And why did you want today to be just on that?
So the other day I was doing a one-on-one session with somebody and we started talking and they were asking some questions that were like really high level. And I was like, wow, this person really has done a lot of reading. They know a lot of this. And then I brought up about fluoroquinolone antibiotics. And we're going to talk more about fluoroquinolone antibiotics shortly. But when I brought that up, they were like, what are you talking about? They had no idea that there was a connection between fluoroquinolone antibiotics and connective tissue. And so I realized that a lot of people are getting into the weeds. They know a lot of really detailed things, but they might not know the basics. And also on this show, we have done a lot of high level deep dives, but I thought, oh my gosh, what are the like basic things that we haven't talked about? I don't think we've talked about fluoroquinolones. Like this is a really important topic, so we need to talk about it.
You're like, who knows the least about it and thinks fluoroquinolone might be a Harry Potter spell? I hear you. So what do you think's being missed the most in general with everybody? Like if we just in the spirit of boiling it down to like the most simple takeaways for folks.
Sure. And this is not specific to fluoroquinolones, by the way. This is just like some of the things that are being missed most often. So
I
number
appreciate
one,
it because I don't know how to say it.
yeah, that's okay. I'll insert myself whenever we have to say that word. Took me a long time to practice, and I'm terrible at pronunciation. I'm really bad at it. Okay. So, first thing is less is more. We always want to be looking for the minimal effective dose. And I find oftentimes people are taking a whole lot of medications, a whole lot of supplements, and sometimes higher doses than what they need. So, oftentimes when I'm working one on one with someone, the first thing we do is we look for medications and supplements that they might want to work with their prescriber to decrease or to eliminate if they're not really making a difference. We get a lot of training in medical school about prescribing medications, but we don't get information about deprescribing medications. So that's the first thing. The second thing is how small things can really add up. I've said this before on the show. I'll say it again. When I was in terrible, terrible pain, I kept looking for like the one thing that would take my pain away. So if something wasn't completely successful in my mind, I would stop doing it. So, for example, like using a TENS unit, I tried that and I was like, okay, it wasn't earth shattering, so I stopped using it. Whereas a lot of the times, if you can find five things that each give you 10% improvement, now you have 50% improvement. So small things can really add up. Another point I wanted to make is that we often notice when things are going less well, but we don't notice when things are going better. So it can be really helpful to keep a journal, track your symptoms. And I know people know like keep a journal and track your symptoms, but I'm saying also looking for any signs of improvement when you're trying something new, because otherwise you might miss the subtle signs and you might not be as diligent about following through. But if you really start to look for those things, I think that people can, get more bang for the buck because we do want to take advantage of like the placebo effect and be able to really capitalize on those things. The placebo effect and the nocebo effect, which is the opposite, are very real. And I'm not saying like just go take placebos and that's going to make you better because obviously it's not. But at the end of the day, the whole goal is to get you feeling better. And sometimes we need to kind of do a little psychology with ourselves. So, one thing that we know is expectations matter a lot. There's been some fascinating research looking at the brain and how blood flow is altered when we have different expectations. So, if somebody's told this is going to make their pain worse versus if they're told they're going to make the pain better, and they're injected with the same medication, different parts of the brain light up. So think about that a second. You're injecting them with the same medication, but in one condition, you're telling them this medication is going to make your pain better. And in the other condition, you're telling them it's going to make your pain worse. And you're getting the same medication IV. This is a study with an IV medication, and different parts of the brain lit up. So we want to use our brains to try to help us feel better.
So when you're talking about the nocebo and placebo and all the cognitive aspects, sure, you earlier brought in that this conversation kind of encompasses more of a full systemic dialogue and needs to be addressed from that perspective. Can you talk a little bit more about like what you meant by systemic?
Right. So because connective tissue is everywhere in the body, these conditions can affect every single system in the body. And a big message that I want to convey, especially to the clinicians out there, is these conditions are not benign. I still see in people's medical charts the diagnosis, benign joint hypermobility syndrome, which really tells me something about that person and their background. Now, I can't keep up on terminology in other fields, and I know that, but at the same time, I really hope that people will stop using this term, because in 2017, when the new criteria came out by the International Consortium, they removed the term benign joint hypermobility syndrome. And that really conveys a message that these conditions are not significant and that having hypermobility is not a problem. For some people, they can have joint hypermobility and they don't ever develop symptoms. But for a large number of people, they have joint hypermobility and they have symptoms associated with joint hypermobility. So they have symptomatic joint hypermobility. And again, it can affect every single part of the body. So we can end up with, gastrointestinal problems and cardiac problems and neurologic problems. And one analogy that I like to use is to think about the connective tissue and EDS and HSD as being like a house. So if you think of the body like a house, and for a long time we treated EDS and HSD like it was problems with the doors and the hinges, which I kind of like that analogy because you think of joints and doors and hinges, right? So loose joints, clicky shoulders, knees that hyperextend, and ankles that roll. But connective tissue is not just in the hinges. It's in the foundation, it's in the walls, it's in the plumbing, it's in the electrical system. So if we go on with this analogy, connective tissue, it's also in the roof, the insulation, and the supports that hold everything together. So if the building material is different, we would not be surprised that problems show up in more than one room. Because if you have a house and you have a problem with the foundation, then that can affect every other part of the house. Because if the foundation starts to collapse, right, you can end up with like the electrical wiring coming apart, and it can cause the plumbing to come apart. And so it's the same thing with connective tissue. It can affect every single part of the body because the connective tissue is what holds the whole body together. So the joints can be unstable. The muscles have to work overtime to hold the body together. The blood vessels might not regulate blood flow well, so you can get dizziness, heart rate changes, exercise intolerance, or POT symptoms. In some people, the blood vessels or nerves can be compressed, and the body can compensate and grow new blood vessels in ways that can cause other symptoms. The gut can struggle with motility. We were talking about gastroparesis earlier, where there's slow motility through the stomach. That can happen. That can contribute to reflux, gastroesophageal reflux, and SIBO, or small intestinal bacterial overgrowth. We also see nausea, bloating, constipation, abdominal pain, etc. We see nerves that are irritated and sensitized, and we can see, again, the compression syndromes like thoracic outlet. The immune system becomes more reactive with allergy-type symptoms, mast cell activation symptoms. So the patient can look really complicated, but the symptoms are not random. There's just cracks in different rooms of the same house. Now, we also have to remember that every symptom is not necessarily from EDS or HSD. We need to keep a careful eye for new and unrelated problems, because assuming that everything is due to EDS or HSD can also cause its own set of problems. So for many patients, that kind of a framework, I think, can be really helpful, and for clinicians.
Yeah, it sounds like, and that's important at the end there. It sounds like it's don't be too addicted to the EDS diagnosis always, but at the same time, when you are looking at these kinds of issues, I could tell that it hit an emotional nerve for you about the benign phrasing and
Oh,
making.
interesting.
Yeah, and I think that's really interesting, and I bet everyone listening or watching picked up on that too. Like you clearly We're being very diplomatic. I want to poke at that a little with you there, is that sounds like this is a long-term problem, it sounds like, in the practitioner space, huh?
It is. And for me, even still, as somebody who specializes in these conditions, I literally was on the phone this morning trying to get an orthopedic appointment because I did something weird to my foot the other day and I'm literally hobbling around my house right now. And I'm wearing this brace on my elbow because that's flaring up. I haven't been able to go to my exercise classes this week. So
Sounds
even
benign.
yeah, it sounds benign. So even when we get to a good place, and I think I probably was bragging a little too much recently, even when we get to a good place, things happen and the path is not linear. Getting overconfident is probably not a good idea.
Interesting. Yeah, I before we move on, I do want to ask a little bit more just on, do you think that there is, I just want to, this is me being naive about the benign part, but do you think that there is a reformation or reform needed in how practitioners are educated in long-term treatment, um, long-term treatment with hypermobility and EDS kinds of issues? This is me being very naive, but that's what I'm getting from that also, is that it sounds like it's not lack of caring on their part, but a lot of practitioners just aren't educated on it. So they just do what they were taught to say or do and mark in charts, right?
Well, I'd say there's several problems. One is the production pressure in our insurance-based healthcare system. Trying to see 30 or 40 people in a day if they have conditions like this, that's obviously really challenging. You have like 5 or 10 minutes per person. So, number 1, clinicians need more time to really, work with these patients, and a lot of healthcare systems don't give people that kind of time. And I've actually had clinician friends who were told you can't take any more EDS patients because you're taking too much time with them and you're not seeing a high enough volume of patients in a day. So I think oftentimes people don't understand that clinicians can be under a lot of pressure when they're working for a big health system. And I'm not saying big health systems are bad. We need them and they can do a lot of wonderful things. But at the same time, it's often not the right fit for somebody with these complex conditions.
So before we keep going, I want to dig in a little bit more there, because I think there's something very very helpful for everyone listening or watching. When you talk about how there are practitioners, and whether it's your PCP or whatever, and that for better or for worse, institutionally, they do at times, you will be sitting down and looking your doctor in the eye and realizing it's not that they don't care, but this is their job. They have to keep things moving. Do you have any helpful constructive advice about, not to be combative, but to be constructive as a patient, if you find yourself sitting with a practitioner who you like and you trust, but you can tell you don't want to like start crying or yelling at them, but how do you help make sure that you're being attended to properly or saying the right terms to make sure that they are taking it seriously enough?
So I have a few tips on this. Number 1, the more you can organize your information ahead of time, the easier it's going to be for them to digest the information and help you. So I have some patients who are becoming really outstanding experts at this. They put their information in AI and they have AI organize it by system. For example, like they put in their symptoms and they have it organized by system. They have like their team in there. So they have all their doctors' names and they bring these documents with them to appointments and they'll have like pending workups, what the latest results were, and things like that. Make it easy for your doctor to help you by doing these kinds of things. And this is a perfect use of AI right now because you can put all this into AI and you can say, organize this for me, keep it concise, keep it like as brief as possible, and that helps your doctor to focus. So I think that's a really good thing for people to do. And I think that it's perfectly fine to suggest, I'm concerned that I might have Ehlers-Danlos syndrome, the hypermobility type, or whatever it might be, but to also describe your symptoms, how you're feeling them, and not say, I have kidney pain. Say, I have pain and it hurts right here. Don't label it. Just say what it is that you're feeling. And then later on, if they're not picking up on what you're thinking, say, I'm worried that it might be my kidney or I'm worried that it might be EDS. So the first thing is organize your information and present it in a way that it is as subjective as possible, like you're like a reporter telling a story. I also think that it's really helpful to share resources and to share what you've been reading and let them know what the sources are. So, for example, I have so many people who tell me that they share this podcast with their clinicians. And oftentimes I get messages from clinicians who are like, I listened to the Bendy Bodies podcast because a patient told me about it. But how you bring it up is really, really important. You don't want to make it seem like, you don't know anything. You want to be respectful and, you want to say, I found this resource, whether it's the Bendy Bodies podcast or something that the Ehlers-Danlos Society puts out or something else or a journal article or whatever it might be. You want to say to them, I know you're super busy. I wanted to share this resource with you because I think it might be an efficient way to learn if you're curious about these conditions, because it's my understanding that I might not be in the minority, that these conditions might affect a lot of people. And I keep hearing on this podcast that if clinicians understand more about these conditions, they can actually help a lot more people. So it's, to kind of make them get the buy-in, right? To make them feel like, oh, if I learn about these things, I'm going to actually be able to help a lot of people who have not really been able to be helped in the past. And then the last thing I want to say about that is empathy. And I like how you said, it's a clinician that you like, that you're working with, because oftentimes I hear people say, well, my doctor didn't know how to pronounce Ehlers-Danlos. That doesn't make them a bad doctor. If they are empathetic and curious and want to help you, that's what you need. You don't need them to be able to pronounce Ehlers-Danlos. Trust me, there's lots of doctors who can pronounce Ehlers-Danlos, and you don't want them because they either misunderstand these conditions or they have a lot of, stigma associated with them. They don't think that they cause pain or things like that. So the most important thing is to have a clinician who is curious and empathetic.
So then on that note, Dr. B, you know what? I am not you. I do not write I do not write the Bendy Bodies newsletter, but would it make sense to do a newsletter of like Dr. Bluestein's advice of constructive prompts to give your AI when giving your information to help condense down and give your practitioner what you need to know tied to EDS or any of these hypermobility conditions? Would that, because I have a number of prompts that I have for different AI engines that I'll do along with my documentation for things. How do you feel about maybe, because I want to know what you would suggest saying to the AI of like, for example, based on understanding of this isn't this, please, to help my doctor understand it from this perspective and this perspective, boil down the attached documents in this way. Like, would that be something you would maybe do a newsletter about?
I think that's a fantastic suggestion for a newsletter topic. So I will definitely do a newsletter about that. My newsletter is on Substack and it's hypermobilitymd.substack.com. And I love doing newsletters because it gives you time to digest, organize the information. And I am going to be doing a series on what different specialists need to know about EDS or what I think they should know about EDS, and also what PCPs should know about EDS. So this is kind of a complement to that series that I'm planning on doing. So I love that idea. Thank you. That's a great
Yeah, it's like the
suggestion.
patient side of it to kick things off,
Right,
right?
right.
Yeah. So we can move on, but I that just came to mind as something that I was going to ask you on the site anyway and be like, what do you suggest I do? Because I'm dealing with some stuff and might as well do it for everyone. You've mentioned antibiotics a number of times now, and it's very clear that there are medication risks, obviously, and very significant and substantial ones. And obviously, AI is playing a big role these days also in the research for better um, antibiotic resistant issues, especially fluoroquinolone antibiotics like ciprofloxacin, levofloxacin, moxifloxacin. Did I say this right, Dr. B?
You did.
Yay!
Perfect.
Why do you think people with connective tissue disorders, why do you think these require a little extra attention or consideration?
So, as you said, these are fluoroquinolone antibiotics, and they carry an FDA black box warning. And so, what a black box warning means is it's the FDA's strongest warning for serious or potentially life threatening risks. And for all of these, there are black box warnings. So, what these are include um, tendon rupture, tendon pain, tendonitis, peripheral neuropathy, effects on muscles, joints, and the nervous system, as well as an increased risk of aortic aneurysm or dissection in certain high-risk patients. So that means that these antibiotics can affect connective tissue in a negative way, and they can cause your aorta, which is the biggest blood vessel coming out of your heart, it can cause that to get enlarged or more stretchy. And it could even cause it to rupture. It can cause your tendons to rupture. And so it's really important for everyone who has a potential connective tissue disorder to be aware of these things, because we might be even more vulnerable than the general population. Reactions can be delayed by weeks or even months. And the message is not to never use them, but to really be thoughtful, especially if you're a prescriber. Do not use them casually if there's other safer alternatives. And you also want to know the names that you mentioned earlier: ciprofloxacin, levofloxacin, and moxifloxacin. And if you are prescribed these medications, ask, why are you doing this option? Is there a safer option for me? And if you do develop, new pain or unusual symptoms, definitely make sure your clinician is aware really promptly. People talk about being floxed, Floxed, floxed. There are people who say that they were functioning at a completely different level, and then they were prescribed one of these antibiotics, and the wheels fell off the bus. Their body completely fell apart. So just like when people have gotten COVID or mold exposure or tick-borne illnesses, this is another time that we often see people with connective tissue disorders experience a huge acceleration in their symptoms. There are people who have gotten these kinds of antibiotics, the fluoroquinolones, and have gotten significantly worse or new onset of connective tissue symptoms. So it's just really important to be aware. If a person has multiple antibiotic allergies, you start to get more and more limited in your choices. So it might be that this is really the only choice for a particular person. So it's really important to discuss with the prescriber your concerns, but they might tell you, well, look, you have a penicillin allergy, you have a cephalosporin allergy. So there are times where these antibiotics are completely appropriate. They're used for urinary tract infections, they're used for respiratory tract infections, and they are very effective as antibiotics. And of course, this doesn't happen to everybody by any stretch of the imagination. It's just important to be aware of, because these are potential risks. And I don't know this for a fact, but there's probably, because it just makes sense, a dose relationship. So maybe rather than a 10-day course, if a 7-day course is also sufficient, maybe that's another consideration as well.
No, that's really interesting. And I personally, and I'm sure others listening and watching will agree, I think that's really interesting context to get from you, because I always hear about antibiotics and there's good and bad stuff with it. I mean, they're overall force of good, I imagine, but it's helpful to understand from your perspective what are things to be aware of and be thinking about with some of these more correct me if I'm wrong, these more niche or very intense treatment antibiotic medications. So yeah.
Well, actually, ciprofloxacin is prescribed a lot, and levofloxacin. They're prescribed a lot. So I would not actually consider those to be niche antibiotics. They're prescribed all the time. Again, they're very commonly used for bladder infections and for respiratory infections. So these complications happen very rarely, but they're significant enough that the FDA feels that there needs to be a black box warning, and that's why people need to know. But it's definitely not, don't ever use them, because there are times that they are the best choice. That's the question, is what's the best choice, factoring everything in. So we're going to take a quick break, and we're going to talk when we come back about genetic testing and how variants of uncertain significance are so often misunderstood, and what to do if you have a phenotype that is really strong for a certain rare type of EDS, but you don't have positive genetic testing. What should you do? How should that be handled? So we're going to take a quick break, and we will be right back. After a full summer day, there's nothing I love more than putting on incredibly comfortable clothing like the Cozy Earth rib knit pajamas. These are my favorite pajamas to sleep in because they keep me so cool even on the hottest of summer nights. I also love the Cozy Earth all-day tee, and I really could live in this all day, every day. I also love the fact that Cozy Earth stands behind everything they make. They offer a lifetime warranty and 30 days of hassle-free returns if anything isn't right with their clothing. This summer, Cozy Earth's all-day tee and rib knit pajama set are the two things that I have been reaching for over and over again. Made from viscose, from bamboo, they're breathable, soft, and built for the season you're actually living in. Summer lives here, and honestly, so does cool and comfort. Head to CozyEarth.com and use my code BENDY for an exclusive 20% off. That's code BENDY for an exclusive 20% off. And if you see a post-purchase survey, mention that you heard about Cozy Earth right here on the Bendy Bodies podcast.
during the break, we were talking actually about, there are a lot of needs for good practitioners out there and good staff who are knowledgeable about all of these things and are thoughtful and engaged and present, which is very hard for everyone in any career these days, or ever. Dr. B, you mentioned that you had a little plug for those who might be in the job market right now, huh?
Yes. So I'm so excited about our partnership with the University of Virginia Health EDS and Hypermobility Disorders Center. And it's been super fun doing podcasts with their medical director, Dr. Dacre Knight, and with their associate medical director, Dr. Ina Stevens. So UVA Health is hiring right now for their EDS and Hypermobility Disorders Center. And I believe that currently they have open positions for a dietitian and nurse practitioners. However, I'm sure that they have ongoing needs. So please do check out their website. We're going to read it at the end. So please check out the UVA website for their EDS and Hypermobility Disorders Center for open positions.
No, I think that's great. I think it's great that there's a lot of people out there who we know are needing to get the word out, needing to hear about it, who need jobs like this and are ready for it and are seasoned and good to go for it. So I think it's really great that through the partnership we've all been seeing you do with UVA. I think it's great that you're asking everyone to get the word out, because this episode is really shining a light on how important it is for good, proactive, present individuals in these practices, right?
Most definitely. And you need a team. I mean, as much as any one of us can really help people quite a bit, especially when we can work with them one-on-one, every single person with these conditions can benefit from having a team. And that does include, you know, all the different specialists, a dietitian, occupational therapist, physical therapist, et cetera.
So, so UVA had a question for you, which is, can you help get the word out? I have a radical idea here, Dr. B. Why don't we do another question from your audience?
Okay.
All right. Here's the next one we've got. A lot of patients are told your genetic testing was negative, so you don't have a rare type of EDS. Is that always true?
So the short answer is no. Genetic testing is incredibly valuable, but it's not perfect. So I feel like where there are things that we can test for, a lot of people think, oh, that tests for everything. But a negative genetic test does not automatically rule out every rare subtype of EDS. We know a lot in genetics, but we don't know everything. And we know that the clinical picture or the phenotype is really important to take into consideration. I've worked with some people one-on-one that have some of the very rare and unusual findings of a more rare subtype or a genetically identified type of EDS, and their genetic testing is negative. That doesn't mean that they don't have that type. Maybe we just haven't identified the gene yet. So it's really important that we be thinking very, very carefully about the phenotype. Does this person have some of the red flags that we have discussed and we have listed? We discussed those with Dr. Claire Frangamano and Dr. Paul Deep Atwell, and we also have a red flag document that's on the bendybodiespodcast.com website. So it's really important to consider, does a person have some of these red flags like ruptured organs and dislocated hips at birth and, pneumothoraces, which is when the lung collapses, and some of these other things. So it could be that the variant is present, but it's not detected in the testing method that's used. It could be that the variant is found, but it's classified as a variant of uncertain significance because we don't yet have enough information to know whether this variant is disease causing. And so clinical judgment really matters a lot. And I find this to be most important if somebody has some of the findings that are consistent with vascular EDS, because of the fact that that type is so much more life-threatening. So which I have seen happen, if somebody tests negative for the vascular type and the other genetically identified types of EDS, and somebody labels them as having hypermobile EDS, and they go to an ER with chest pain, the ER doctor's not going to be thinking about an aortic rupture or, if they have the worst headache of their life, they're not going to be thinking about an aneurysm rupture because the chart says they have hypermobile EDS. So that's why the phenotype or the clinical picture is so important.
Yeah, and I guess to take us full circle, then it's so important. It sounds like to know how to best aggregate, track, and communicate what you're going through with your practitioner, because what's happening practically in reality sometimes doesn't align with certain tests. And I learned that firsthand. I've had really severe allergies my whole life to like things I touch, like animals and stuff. And I did a skin test years ago, and it showed I'm allergic to everything. I did a blood test, I think last year, with a different practitioner, and it showed I have no allergies to anything, even though I always have allergies. And they're like, "Oh, you have no allergies." And I'm like, "I definitely do." And I was definitely like, the first time I was like, "Oh, okay. These labs are far more complicated and less just like black and white, right or wrong, than we'd think for any autoimmune or any other physiological disorder, I'd imagine." So
Yeah, that's super interesting because we know that if somebody has mast cell activation syndrome, they're going to have allergic-like symptoms, but their allergy testing is not necessarily going to be positive because mast cell activation syndrome is not an IgE phenomenon. So that's super interesting.
So then, okay, on the flip side of that, when do you often see genetic testing be something that is really fruitful and that you've seen have a really good batting average in the work you do?
So it's excellent for the monogenic, means one gene or known gene disorders. So whether it's, Lewy Dietz, vascular EDS, Marfan's, those kinds of conditions, it's excellent for that to confirm. If you have a positive result, it's very, very helpful. A positive known pathogenic gene. So it can identify those specific EDS subtypes that carry very important management implications. It can also help with surveillance, family counseling, and risk assessment, and it can help clinicians know when they need to monitor for vascular, ocular, skeletal, or organ related complications. But a result should always be interpreted in the context of a patient's clinical presentation. So, in that example that I gave earlier, if somebody really looks like they have vascular EDS, but their testing is negative for it, I think most clinicians who have been in this space long enough and treat enough of these patients, they will treat that person as if they have vascular EDS, even though the testing is negative. Because there are, reasons that we discussed earlier. There are reasons where there could be a false negative. So that person might be, it might behoove them to do the type of screening and things like that that you would do for vascular EDS in that situation.
That makes sense. And look, I think I think a lot of people at this point have done like the 23andMe's and like at home things. Do you have any hot takes on the world of like, what's the direct to consumer at home, off the shelf genetic tests that people can buy and order and do?
Yeah, that's a tough one. I'd say my biggest criticism is number one, that they aren't necessarily using the same techniques, but even more importantly, their reports. I see these reports because patients bring them in, when they see me one on one, they'll submit their reports ahead of time. And in my opinion, these reports really overstate the findings. So if you get a genetic test through a medical company, they will say this is a variant of uncertain significance, and they'll explain what a variant of uncertain significance is, et cetera. But what I find when people get genetic testing through some of these other companies, I feel like they really overstate the findings. I feel like they really want the patient to feel validated, which is, of course, a wonderful thing. But I feel like in doing so, they really overstate and they're variants of uncertain significance because we really don't know what they mean. So that's my biggest frustration with those tests.
Interesting. This is me very naive. Don't no one hold me to this, please. I could be very wrong on this takeaway, but it occurs to me that they probably have a financial motivation to have a number of positive results so that they can show that as a company that they are successfully diagnosing X, Y, and Z, right? Like there's a motivation to test positive. Am I wrong? Like if it's like if it's on the if it's on the fence and it's balancing, they might, maybe I'm way off on that.
No, no, I think you're right. I think they're trying to err on the side of being validating for the person. And so they are taking these little bits of information and running with it rather than taking the conservative and super factual approach.
Yeah. There's something in psychology that I always like to bear in mind, which is the term confirmation bias. That
Yes.
yeah, that when people deep dive into something, and ask a lot of questions about something, you can sometimes tell that all they want is whatever answer helps reinforce the conclusion that either they fear or they expect. But either way is the one that they are pursuing. It's something in life for all of us probably to just be aware of with the things we do. Um, Or in court, they'll call it leading the witness. But,
Yes, yes. I want to give an example of that. So I saw somebody for one-on-one coaching. Gosh, it had to be over a year ago now. But there was an opening last minute, and they scheduled like late the night before, and they were in an absolute panic. They had just gotten their results back from this was a medical lab, and they had a variant of uncertain significance that was associated with one of the genes for Louis Dietz syndrome, or that can be problematic in Louis Dietz syndrome, which is one of the connective tissue disorders that's more rare. And they went to the websites for Louis Dietz and started looking things up. And they started going through the, symptoms that are listed. And they're like, I have this, I have this, I have this, I have this. Well, when we discussed it, though, what I pointed out to them was that, yes, you have these things that are on this list. And maybe from a numeric standpoint, you might even have more of the things than fewer of the things. But the things that you have are the things that are the least specific. The most specific items that are on that list, you don't have any of those. So I think that confirmation bias is a super important concept for everyone to understand. And it kind of comes back to what I was saying earlier about, report your symptoms. Please don't try to label them. I like what you said about writing a newsletter about how to use AI to prepare for your appointments, because it also can be hazardous. Because I have people who are like, I'm convinced I have a kidney stone because I got this result. Well, I know what they're doing is they're putting it into AI, and they're then thinking I have a kidney stone. But really, that's something that can show up when you have more concentrated urine, for example. I had somebody who thought they had cancer because they put the results into AI, and I'm like, that's not what that means. So confirmation bias, I think now with AI is an even bigger problem than ever before. So we need to be very careful. So maybe again, getting back to the prompts, I'm gonna make a note of that so that I can give people prompts for like, how do I avoid confirmation bias, or can you help me avoid confirmation bias?
yeah, I'm really excited to. I imagine it's going to be kind of an ongoing project for you that will be adapting. But I think the idea of having that general prompt to guide it, I think we're learning more and more with AI as we're all getting more integrated with AI in our lives, that blanket dropping things and having to do assessments isn't as constructive as having the right prompt sets for it. So
Yes, yes. The prompts are everything.
yeah, and it also, ironically, even before AI, we had WebMD, where if you stub your toe, you go on there and it says you have terminal cancer and will die within a week, right? So it sounds like it's all about compiling, aggregating the right prompts, the right information, taking it, working with your practitioner, but not all, but being self-aware enough to check in and see if you're driving yourself towards a conclusion that you're not going to stop till you find some evidence that you are right about your worst fear for peace of mind, but it actually is to your own detriment, I would imagine. Um, but then again, what do I know? But I want to get one more question in before we're done. But I think just to wrap it up on this one, any other takeaways that you want us to consider um, about the world of genetics and our tests and everything?
Sure. So just, remembering that genetic testing is only as good as our current knowledge, and it can't identify genes that we haven't discovered yet. So that's really important. Not all variants are harmful. And I see people all the time talk about MTHFR, which is a methylation gene, and they talk about the mutations. And we really should be calling those variants because they're so common in the population. So it's really important to be thinking about, we all have these genetic variants, and so they're not all causing disease. Another point I wanted to make about direct to consumer testing from the geneticists that I've spoken to, they do not make a diagnosis based on direct to consumer testing. So if you're trying to figure out how to utilize the amount of money that you have to spend on your health, just give that a second thought, that a geneticist or other doctor is not going to take your direct to consumer genetic test, most likely. They're not going to take that and make a medical diagnosis based on that testing. And also, a positive direct to consumer result is often not found in medical grade testing. It might be, but it isn't always. So whenever possible, get medical grade testing if you can.
I think that's fair. Yeah. All right. So I think we have time for one more question, and I think this will be really interesting for everybody. I don't know if listeners, viewers know this, but we get so much feedback about how much everyone enjoys hearing you talk about this topic. So I'm really curious to kind of hear you let loose on it. But here's the question. You often talk about mast cell activation as something that can radically change the whole clinical picture. What do you mean by that?
So mast cells are present everywhere in the body, and they're in places where we interface with the environment. So they're in the skin, they're in the respiratory tract, the GI tract, etc. So they can affect so many things. And I think that this is a topic that a lot of people are so interested in because not that we want to turn this into the misery Olympics, but gaslighting for EDS and HSD is really bad. Gaslighting for MCAS in some ways is almost worse. There's so many doctors who say you need to have a tryptase test, and if your tryptase test comes back normal, then you can't have MCAS. If you don't have anaphylaxis, then you can't have MCAS. There are multiple different schools of thought on the diagnostic criteria for MCAS, and my feeling is that we should be casting a wider net because we can help a lot of people when we do so. So, while I do order tryptase testing on anyone that I suspect mast cell activation syndrome in, I consider a negative result or a normal result to be basically not helpful. I don't consider it to be conclusive of anything. If the tryptase does come back elevated, that's helpful because then you know that they might have hereditary alpha tryptosemia or mastocytosis. So, depending on how high it is, you might need to do a bone marrow biopsy, for example. And mastocytosis is when there's an increased number of mast cells. And mast cell activation syndrome refers to when the mast cells are more twitchy and they release their mediators more easily. And we know that MCAS can amplify pain, it can amplify migraines. It can be involved in bladder pain, GI symptoms, endometriosis, migraine, brain fog, sleep disruption, psychiatric conditions, medication reactions, dysautonomia like POTS, fatigue, and food and environmental reactivity. So, treating MCAS can actually change the entire trajectory. And I can't remember if I told this story before or not, but my second patient that I ever had after I opened my clinic, the mom came up to me after I gave a lecture someplace and she said, "This is what's going on with my daughter. She has psychogenic non-epileptiform seizure disorder," which basically means that they think that she's having this like seizure activity, but she's making it up. And she's having these other symptoms, and she had a known diagnosis of EDS, and I believe she had a known diagnosis of POTS. "Do you think you can help my daughter?" And, I had just barely gotten into this. I knew so little at that point. And I said, "Well, I don't know if I can help her, but I'm willing to try." And so I saw her for her first appointment. I prescribed a number of MCAS related therapies, which included low dose naltrexone and some supplements and things like that. And she came back for her 30-day follow up and she had not had a single episode. And I almost fell out of my chair because I was like, it actually worked. Because, I was so new at this and I didn't know like
Don't
an
tell us that's
antihist.
what our doctors are thinking.
I know, right? And antihistamines, of course, was another part of this. And she had taken her driver's license had been taken away because, obviously somebody can't drive if they're having recurrent seizures. And she was a teenager, so it was huge for her to be able to
Incredible.
drive and have a normal life. So, yeah, so early on, I realized how mast cells can cause such different symptoms in different people. And it really, because there are so many different mast cell mediators, no two mast cell patients are going to look alike, but we just need to be thinking of this when we are assessing our patients because oftentimes treating that mast cell can have an incredible slew of benefits.
And by the way, that must have been such a trajectory setter for you professionally to get that validation, right? I would imagine that must have been like the heavens opening up on you, and you're like, oh, there's something here for me.
That's exactly what it is. And I think that, learning about something in the books is one thing, but when you actually try it with a patient and they come back and say, "I'm doing better," that's what really like, oh, okay, there is something to this. Yeah.
Yeah, I mean, in your case, you were seeing a teenager get a big part of their life back, right?
Yeah, absolutely.
So, look, I know you've talked about this before, but just to keep it all consolidated in this conversation, if anyone's listening and they're like, okay, we've talked about genetic testing, you've talked about MCAS, you've talked about the wide scope, you've said 20% of people potentially affected by this. Do you often recommend people ask their PCP to do certain tests on their own before they even go see a practitioner like yourself for that? Or where do people start if they suspect it?
So if your practitioner is willing to order a baseline tryptase, I think that is a good idea. There are certain things that the practitioner needs to put on the slip. So the sample has to stay cold the entire time. So from the time it comes out of your body, it's not cold in your body. But these mediators are very thermolabile. So as soon as they draw the blood, they need to put it in a refrigerated centrifuge, and then it needs to go in the refrigerator. And it is so important that every step along the transport chain that the specimen is handled correctly. So that's where we probably get a lot of false negative results, is because the specimen isn't being handled correctly. So it's really important for practitioners to understand how to order these tests. For example, whether it's the baseline serum tryptase or giving somebody a slip to get a tryptase drawn during a flare. We need to put these parameters directly on the slip so that the patient knows, the lab knows, et cetera. And I do give people a slip to draw during a flare, but I want to point something out that's really important. Please, please, please do not induce a flare for the purpose of doing the labs. There are people who do that, and then they're in a flare state for months. So I recommend people have that slip, keep it, go to the lab if you get a flare ideally with you're getting the labs done within an hour to 4 hours at the most, which I understand is very difficult in a lot of situations. But please do not induce a flare in order to get the labs done, because then you're going to be really disappointed if it comes back negative. And now you've gotten yourself in a flare that's going to last for a number of months. There are urine tests that we can do as well, looking for prostaglandins, something called N-methylhistamine, and leukotrienes. Again, there are things that we need to do differently with medications. We ideally are avoiding supraphysiologic doses of mast cell stabilizing medications like vitamin C. And there are other medications that we need to stop before doing this testing. So it's important for practitioners to know what those things are. But yes, I think it would be great for more PCPs to order that testing for patients, and that's something that they can do.
I feel like I'm just on air asking you to do more homework, but there's a part of me that's like, maybe that's also something to give people as a draft of how can people mess, because so much is done through I don't know, people go on the different web portals to message their PCPs. You don't always need an appointment now to go over this with them. What are ways to say pretty much, like first step initials, like, hey, I suspect I might have this. Would you be open to ordering A, B, and C just to start looking into it for me? What kind of way can someone ask that to their practitioner? I wonder is also something that I like. I'd be very curious how you would recommend somebody kind of first tee that up to their PCP, because I would imagine if you're a practitioner and you get that message from your patient and it's a mile long list of things, you're going to be like, okay, they're having a moment, versus like, oh, okay, those are easy. Sure. Like, I don't think you need it. Maybe I do, but these are easy. I can just order them for you. And that way it removes that barrier of entry for everyone to get it started.
Yeah, I love that question. And I think the way you worded it was really good, actually. Would you be willing to order these for me? And as we were talking about earlier, and I will write a newsletter about this, because I think this is something that's really important. So I will write a newsletter on how to ask your PCP for MCAS labs and exactly what they need to put in the requisition. Because if you put it in a way such that they can literally copy and paste, they're at least a little bit more likely to do it. Maybe they're not going to do it, but at least you've lowered the barrier to them doing it.
I've actually been meaning to personally for a while, so I wonder if we can report back next time I'm on with you if you and I try it. I'm serious. You can help me draft what I would ask my provider. He's very easy to work with, and I can report back as to how, whether he was receptive or not. Like, actually give a firsthand account of how that went, and you and I can try that
Right.
if you want.
Well, so I have, we all have smart phrases that we use in our EMRs. So I already have all the language there. It's just a matter of putting it in a different format. So I will definitely get that language to you. And like you said, you can report back and let us know
Yeah,
how it
no, I think
goes.
that'd be interesting. I think we're about at time, even though I feel like you and I could do this for hours. Before we wrap, I have a question for you, which is just, we are so lucky to have such an incredibly engaged listener base. I don't want to say fan base because it's not a fan base, it's a community, right? We have such an engaged community around Bendy bodies and the Bendy cinematic universe of Linda Bluestein. No, I feel like you've given so many different ways to learn about and engage with you on all of this, and I don't know how you have the time for it in your life to also work with patients and do it all, but God bless you. Dr. B, what is I know it's a pile of compliments. I'm so sorry for doing that to you. What are the kinds of questions that you're not getting yet that you'd like people who are listening or watching to think about maybe sending your way for the next one of these?
Yeah, thank you for that question, and thank you for the compliments. I did an episode recently. I'm not sure exactly when it's going to be airing, but I did an episode with Abby Phillipson, who has a rare type of EDS, and she spoke at the UVA Health Hypermobility and EDS Center symposium in April. She spoke about how the rare types of EDS, those patients are really feeling like they are not getting the amount of attention that they need because now we've got so much attention going to hypermobile EDS and HSD. And she's right. She's absolutely right. So I felt badly when I heard about her presentation because I had people messaging me about it. And, I'd been doing this podcast already at that point for 6 years. And I had on my to-do list to do an episode about the rare types of EDS or the monogenic types or whatever we want to call them. But I hadn't done it yet. So I think that if people have questions about that, other topics that I have on my to-do list that we haven't done yet, doing an endometriosis episode, doing a thoracic outlet syndrome episode. We talked about doing a gastroparesis episode. Like if I had my way, I would just have probably 5 episodes a week because there's so many things to talk about. I feel like we're never going to run out of ideas. But I think people with the more rare types of EDS are probably experiencing very different problems than the people with the other types. So I would love to hear from those people. I would love to hear what kind of information might be helpful for them, what kind of guests they would like me to have on. I love it when people give me guest suggestions because I always want to have the best possible guest for any given topic. I also would welcome more questions about hormones and perimenopause and menopause because that's a topic that affects a lot of people and suggested guests for any of that. So hopefully that gives people some ideas and they could contact us at bendybodiespodcast.com.
That sounds great. It sounds like also tell us your stories then, not just ask your questions. And that can be stuff that we go through. And yeah. And if any of you know Halle Berry, we all know she's in a whole perimenopause media era of her career right now. I don't know if you know this.
Yeah, I would love that. I would love that. And I know there's a lot of other well-known people. I would love to have, somebody like that that has such an incredible reach, because the challenge is so many people who are listening to the podcast already know that the podcast is relevant to them. And so then they're kind of doing the deeper dive into the medical topics. But how do we reach the people who don't know that this applies to them? So that's the big challenge. That's where we're trying to reach more and more people who are walking around suffering from chronic pain and they have no idea that they have hypermobile joints, or maybe they know that they're quote unquote double jointed, but they just don't know that that's connected. So we need to reach those people because they can be helped. This whole mantra, there's nothing you can do, is just really harmful. So that's why I'm so passionate about the podcast. And I spend less and less time doing one-on-one sessions because I feel like I can help more people this way. So I do still do one-on-one sessions, but I don't do it as much because I feel like this is where I can make a bigger impact.
Yeah. Well, it's clear from what we hear from everyone you are. And again, everyone listening and watching, go to bendybodiespodcast.com. Tell us your stories, ask us your questions. Linda and I really love getting an excuse to sit down and look through all of these together and talk about them and take a pause and go through it. And I know you do on your show too, but selfishly, I feel very grateful to get to do these with you. And thank you for having me on again.
Well, thank you so much, Aron. I love doing these conversations with you. And we will be right back with our hypermobility hack. Thank you so much for listening to Bendy Bodies. We really appreciate your support. It really helps the podcast when you like, subscribe, and comment on YouTube and follow, rate, and review on all audio platforms. This helps us reach so many more people and spread the information to everyone. Thank you so much again, and enjoy the rest of the episode. So today's hack is about living in a constant adrenaline state. A lot of us are doing this. We are constantly like go, 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 and our nervous system is really, really activated. So if you feel like that applies to you, this hyperadrenergic state can actually, cause you to have more anxiety, can cause your symptoms to be exacerbated, and can cause you to feel like wired but tired and feel like shaky inside and things like that. So some of the key things that I want people to know is that, first of all, you're not imagining it. If you feel like this might apply to you, then probably it does. You could look externally calm, but you might be actually physiologically overwhelmed, and your sympathetic nervous system might be on overdrive. This can be labeled as anxiety alone, but it might be chronic activation of your sympathetic nervous system that can worsen pain, fatigue, sleep, GI symptoms, immune reactivity, and functional capacity. So anything that you can do to lower that sympathetic state can be really helpful. So some of the things you can do are to activate the vagus nerve, which is responsible for the rest, digest, and restore, or parasympathetic nervous system. The sympathetic nervous system is the fight, flight, or freeze part of the autonomic nervous system. So some things that we can do to activate the vagus nerve include, there's some wearable devices you can wear on your wrist. There's one that goes around your neck. There's some that go on your ear. You can use a TENS unit on your ear. You can do things like meditation. You can do mindfulness practices. And some of the other things that are free that you can do include humming, singing, and gargling. You can also try cold water plunges or sticking your hand in cold water, or activating the diving reflex, actually like sticking your head in cold water. Of course, talk to your healthcare practitioner before you consider doing any of these things. But those are some things that can help with activating the parasympathetic nervous system and calming down that constant activated adrenaline state. Thank you for listening to this week's episode of the Bendy Bodies podcast. If you'd like to go deeper, I share additional education, clinical insights, and resources in my newsletter, The Bendy Bulletin, which you can find on Substack at hypermobilitymd.substack.com. You can also help us spread the word about connective tissue disorders by leaving a review, sharing this episode, or sending it to someone who needs it. These small actions truly make a difference in raising awareness about these conditions that are still widely misunderstood. And don't forget, full video episodes are available every week on YouTube at Bendy Bodies Podcast. As many of you know, my passion is helping people better understand and navigate symptomatic joint hypermobility. In addition to my clinical and educational work, I offer one-on-one coaching, professional mentorship for healthcare professionals, and expert witness services. If you'd like to learn more, please visit the services page at hypermobilitymd.com. You can find me, Dr. Linda Bluestein, on Instagram, Facebook, TikTok, X, and LinkedIn, all at Hypermobility MD. As part of our collaboration with the UVA Health, EDS, and Hypermobility Disorders Center, we also want to share a few helpful resources. For questions or appointment inquiries, you can contact them at ruvaedscenter@uvahealth.org. That's the letter R, uvaedscenter@uvahealth.org, or call 434-243-8200. Our incredible production team is Human Content. You can find them on TikTok and Instagram at Human Content Pods. We love bringing on guests with unique perspectives to share. However, these unscripted discussions do not necessarily reflect my views or opinions. Furthermore, perspectives expressed within Bendy Bodies Media, including this podcast, do not reflect the views or opinions held by Human Content, Inc. Although we may share healthcare perspectives on this podcast, no statements made on Bendy Bodies should be considered medical advice. Listening to or watching this podcast does not constitute a doctor-patient relationship. Please always consult a qualified healthcare provider regarding your own care. For information about the Bendy Bodies program disclaimer and ethics policy, submission verification and licensing terms, HIPAA release terms, or to get in touch with us, please visit bendybodiespodcast.com. Bendy Bodies Podcast is a Human Content production. Thank you for being a part of our community, and we'll catch you next time on the Bendy Bodies Podcast. Thank you so much for watching. If you enjoyed this video, give it a thumbs up and leave a comment below. I love getting your feedback. Make sure to hit that subscribe button and ring the bell so you will never miss an update. We've got plenty more exciting content coming your way. And if you're looking for more episodes, just click on one of the videos on the screen right now. Thanks again for tuning in, and I'll see you in the next episode.